come and talk with us. The OPQC has worked on NAS. Several of you are here from that project, the neonatal abstinence syndrome. Mary Applegate, the medical director at Medicaid, asked us to move upstream, as Susan showed, and really try to spread what's been learned from the 4 Moms Plus sites. And so we have the majority of attendees are maternity care providers here as we're working to really build support services for women during pregnancy. One of the other things that we recognize and that Dr. Applegate has asked us to address, I think for those of us who have had a newborn, that's an incredibly stressful time. Those next 6 to 12 to 18 years are difficult. And so we're asking women who are dealing with addiction, with recovery, we give them a lot of support, and then often that support ends when they're discharged from the hospital. We've heard some great presentations about how to keep that going, but I think what Dr. Applegate has asked us to do at OPQC is explore options for really focusing on the mother-infant dyad for that first year. And you heard some great things, co-location with family medicine, centering that continues, some of the housing support. So I think in the way that we've begun to think about useful strategies for NAS and standardize those, where we're beginning to work then and spread some of the good work that's been done in the Moms Plus program to maternity care providers. We want to begin to think about how do we support the mom and baby after discharge from the hospital. So as a part of that, we wanted to invite someone who is working on that and who can share her and her team's experiences with it. It's really a pleasure for me to introduce Eileen Costello. We met, I realized this morning, almost 30 years ago. You probably think we were in preschool then, but we were actually young pediatricians who met at an evidence-based week-long seminar, which involved a lot of late-night talks. I was pregnant with my first baby, and we've stayed in touch, although not as much as we'd probably like over the time, and connected over family and work efforts since then. Eileen is a Boston native, so we're probably going to hear a bit about the Red Sox when she comes up. And if you didn't know she was a Boston native, you would know it as soon as she started talking, or soon thereafter. She is incredibly accomplished and is also very modest and humble. She went to Harvard Medical School, then to Harvard undergrad, Northwestern, I think for med school, went back and did her residency at Boston Medical Center, which is well known to those of us in pediatrics and in medicine as really being a place that tries to live a lot of social justice in its healthcare work, and tries to really do great things there. She is, I had to ask her for her titles, because when we see each other, I never ask about those things, but she's now Chief of Ambulatory Outpatient Pediatrics at Boston Medical Center, a clinical professor of pediatrics there, medical director of the primary care clinic, which I think has 14,000 patient visits a year, and she's also medical director of what's called the SOFAR clinic, which you're going to hear about. Eileen has also won multiple awards for humanitarianism and for community service, but I would take the whole hour to list them all. So yeah, and she just said, I wish my mom would be here to hear this, so I'm going to write her a note after this. So Eileen, we're so happy that you're here, and thank you so much.
Thank you, Carol. Hi, everybody. I'm really delighted to be here, and I just want to start with a disclaimer, which is that I'm really a primary care pediatrician. I'm not an investigator. I'm not really an expert in anything other than taking care of kids in my office. I came back to BNC after being in primary care practice in community health centers for 25 years, 3 years ago, and found myself very drawn to this population of mothers who had gotten care in Project Respect, which is our OBGYN program for women with substance use disorders. And I realized that even though I'm at the most social justice hospital in America, that not every pediatrician is really all that interested in taking care of this population, and that as a profession, we have a lot of work to do to sort of elevate the care of families that are affected with substance use disorders. So that said, let me just see if I can figure out how to advance the slides. And do it, just so you know. The home of the world champion Boston Red Sox. I had to get in there. So far stands for supporting our families through addiction and recovery. And this is really at the demonstration project phase. We started in July of 2017. And we have a really, really long way to go. But we're learning a lot, and it has been the most amazing experience. So my objectives for today are to briefly review what little science is available about the long-term impact, developmental outcomes of kids exposed to opioids in utero, and to discuss our new model of trying to take care of babies and children, and to talk about what future things we'd like to do. As a pediatrician, particularly with this really vulnerable patient population, I feel like the way to mothers is through their children. And moms are much more likely to interact with primary care pediatricians than they are with any of their adult providers in the first year of babies' lives. They're there a lot. They call on the phone a lot. They are very eager to take care of their babies, and our goal is to help them take care of themselves at the same time. So I'm going to just start with a case that kind of outlines a little bit of what we're up against as a primary care practice taking care of these families. So because of the new protocols, a lot of babies are going home from the hospital much, much sooner than they were 10 years ago, certainly 20 years ago. So here's the baby, monitored for 5 days after delivery, did not require treatment, discharged home with her parents. 48 hours later, comes into our clinic, arrives 1.5 hours late, which is quite typical, which, as you can imagine, throws a total wrench into our already pretty chaotic clinic. The baby is very fussy, requiring a ton of efforts to console, nudgy, irritable. She's down from her birth weight. The mom is exhausted. She didn't make her methadone appointment this morning because she was so discombobulated. She scored a 13 on the Edinburgh, and this is a very typical first visit for us. And one of the alarming things is the missed methadone appointment, right? But the expectation that a mom with a brand new baby in Boston in February is going to be able to get to a methadone clinic is just crazy, right? It's nuts to begin with. So I know I'm preaching to the choir, so I'm not going to spend too much time on this data because I know you all already know this, but I think the important information here is that high rates of the babies we're seeing have most of their exposure in the first trimester before the moms get into care. I just thought this was really cute, the baby with the cell phone. I just want to talk a little bit about language because I hear about this a lot from the moms when I see them, that they are met with such scorn and derision in the media, in their communities, sometimes in our own emergency room. People call them junkies, telling them that they're already abusing their unborn child. And I think that it is really our ongoing responsibility to change the dialogue to a more compassionate dialogue, to understand how these women ended up where they are to begin with, and to meet them with compassion where they are. This is an old quote from Rolling Stone magazine about the crack-addicted babies, but I think that this kind of concept got into the American mind decades ago and is still sadly alive and well. And so moms will ask me, is my baby a drug addict? And I'll say, no, your baby is not a drug addict. So this is the American Society of Addiction Medicine definition of addiction, and the important part is that the sort of the highlighted area, an individual pathologically pursuing reward and or relief by substance use and other behaviors. Infants are not addicts, and we should not be calling them addicts. I just want to talk a little bit more about language, because when I was in training, neonatal abstinence syndrome was the term that we used, and we used the Finnegan scale, and we are now talking more about neonatal opioid withdrawal syndrome for our opioid-exposed infants. And often we don't start to see symptoms, as you all know, until a few days after the babies are born. And the AAP is recommending that we keep kids for up to a week to observe after they're born. You all know this, and I think that the inpatient teams see these symptoms in the hospital, and as babies have started going home earlier, I'm seeing a lot of this in my primary care practice. And it's really painful to watch a mom with a new baby who is still incredibly nudgy and irritable. We see the most horrible diaper rashes, skin breakdown. We have a particular diaper rash formula that we use that our pharmacy knows what it is, and I give it to every mom. I give that. It's called Questron paste. It's cholestyramine and eucerin together. And I give it to every mom at their first visit, along with a prescription for nystatin, because the rashes are pretty intense. One really poignant story that helped me understand why there's so much yeast in the first months of life. I walked into the women's bathroom a couple of weeks ago at BMC and found a mother washing a disposable diaper. And it just totally shocked me. And I said, what are you doing? And she said, I don't have money to buy diapers. And so that helped me understand why there's such incredible severe yeast in a lot of these babies. So the GI symptoms, the irritability, the difficulty consoling, the difficulty to get babies to sleep is really quite real even when they go home from the hospital. On discharge, what's there to worry about? A friend of mine who's a pediatrician at Dartmouth likes to say this life is an outpatient experience. And I think traditionally the focus has been very much on getting to a safe and healthy delivery and the immediate postpartum period, and very little on kind of how do we support these women afterwards. Steve Chapman is at Dartmouth Hitchcock, and he has a similar program to SOFAR, and a state that's more like Ohio than Massachusetts because it's a very rural state. And his stories are very similar to the ones I heard this morning about transportation and the distance that people have to come into his clinic. So we don't have a ton of data yet because we are just at the very beginning of trying to collect some data. So I have a lot of lessons learned and a little bit of data, and we are just working with our EPIC team I have a dot phrase in my EPIC that I use for every SOFAR visit, .SOFAR, a list of questions I ask every mom. What's your support network? What's your medication that you're on? What's your dose? Who's your therapist? Who's your psychiatrist? How old is the baby's father? One trend that we have noticed, which was very surprising to me, is a huge range in the age from the mom to the dad. So lots of moms in their 20s and early 30s and dads as old as their 60s that have adult children and grandchildren of their own. That really surprised me. It doesn't surprise people in the child protection world because apparently that's fairly common. I didn't know that, and I'm stunned when I see these these kind of old guys coming in with these young women, and these are their babies. Davita Schiff was a fellow with us at BMC, and she's now at MGH, where she's trying to start a similar program to the SOFAR program. The acronym for that, interestingly, is HOPE. But she collected this data in Massachusetts, which I think is probably well known to all of you, that overdose rates trend down during late pregnancy and the early postpartum period, and then start trending up over the first year of an infant's life. I have to say, as a pediatrician, it's one thing to see that on a chart, and it's quite another to know the mother and the infant, and to live through these overdoses and relapses with the mothers and the infants who we've become very attached to. So there are medical needs of both the infants and the babies, right? The prolonged withdrawal symptoms, or just the irritability, formula intolerance, colic, whatever you want to call it. They're not easy babies to take care of when they go home. We do tend to see babies that seem to be smaller for gestational age at birth. Exposures to hepatitis C, I have it on a later slide, but somewhere around 70 to 75% of our mothers are positive for hep C, ocular comorbidities, and the moms are just unbelievably vulnerable in the postpartum period. As was discussed earlier today, the trauma histories of the moms are quite remarkable, and sometimes they precede the onset of the substance use disorder, and sometimes they're a result of the substance use disorder. But as I've gotten to know the moms over time, there are 2 pediatricians in our clinic, I should have said that earlier. I started in July of 2017, just 1 afternoon a week, and now we're doing 3 clinical sessions per week, because the demand is quite remarkable. And over the visits, when I sit with moms, sometimes I don't hear a trauma history story until I've known them for 6 or 9 months. And one of my moms who recently relapsed told me at the 6-month visit that she was worried because she had a 9-month-old who she was with and taking care of the father of that previous 9-month-old, this was 10 years ago, was still actively using, and they got into some kind of a domestic violence situation where he strangled her and left her for dead, and the baby flipped over into a bucket of cleaning solution and died. And so she was being triggered, her PTSD was being triggered by having another baby that was quickly approaching that age, and sure enough, she relapsed. It was fairly predictable. She predicted it herself, and fortunately, we had a little safety net for her, so we kind of knew it was coming, and she came in and told us, which I think is sort of breathtaking. And we were able to create a plan of safe care for her at the 6-month visit, so that there were people around her to support her and her baby as she went through this relapse, and she recovered. We're seeing high rates. We're doing the Edinburgh postpartum depression scale on all our moms, and seeing not unexpectedly very high rates of postpartum depression. And Carol mentioned this, but I think any of us that have had a new baby in our house know how unbelievably stressful it was. I just couldn't believe. I was a pediatrician, and so with my husband and our first baby was like, oh my God, this is not at all what I was expecting. Once you bring him home, it's totally different. And for a lot of our moms, about half of them, it's a first baby, and about half have older children, and some of them have a lot of older children, and we'll talk about that later also. There's a lot of stigma, and there's not always the family support that we would expect. We like to say it takes a village, and I don't know how I would have managed without my mom, who lived 6 miles away from me when my kids were born, because she was just there all the time, and it made a huge difference, and a lot of our moms don't have that. Ongoing safety assessments to make sure that the babies and the kids are safe. Helping parents understand what their distress tolerance is. Sometimes the mom will come in and tell me, I just don't know if I can deal with, life is so hard. I'm like, well, what's so hard? I got a parking ticket. Or, kind of the normal stresses of adult life are sometimes just too much. If you don't have any support, and it's something as simple as, your utility company did something stupid, or you signed up for a credit card and it never arrived, or the kinds of things that happen to all of us that are nuisances, a lot of our moms just describe these things like, I can't handle this, it's too much. We screen at every visit for social determinants of health, including housing. And not surprisingly, there's a ton of unstable housing. One of the things that we have gotten interested in
is the number of domiciles, the number of different places that a child lives in the first year of life, and our highest number right now is 7. So in 1 year, moving from a shelter, like graduating, going to a sober house, getting kicked out because they got in a fight with another mom, living on a couch, and the kids are moving around. I have one 20-month-old who came back to her mom to foster care, from foster care, and had already been in 5 foster families by the time she was 20 months old. And there are all kinds of implications of that sort of thing. So the SOFAR program is sort of an outgrowth of the RESPECT program. So during RESPECT, which is an acronym that I can no longer remember what it means, but the moms are educated during their inpatient hospitalization when they come in to be put on medication-assisted therapy about the fact that they will all be filed on when the baby is born. And so there's no surprises, they know it's coming, and they are filed on, and Child Protection Services comes in, does an assessment, and makes a decision about whether to open or close a case, or take a child immediately into foster care, or send them home with their parents. We do a very detailed social work assessment while they're still inpatient. They all get referred to early intervention before they go home from the hospital, and they all get referred to ophthalmology before they go home from the hospital. So here's our model, such as it is right now. One thing I want to say is we are co-located in the same clinical area with the Catalyst program, which is about a 2-year-old program for young adults, adolescents and young adults with substance use disorders, which is just terrific because we have now a number, if the moms are under 28 years of age, they can get their addiction care, primary care, Hep C care at the same time that the baby's getting their primary care, Hep C care, immunizations. And that has been a really, really great model. If the moms are older, we spend a lot of energy, our care coordinators and patient navigation folks, making sure the mom is connected to the OBAT or to the general internal medicine program where they can get their primary care, addiction care, Hep C care. We have an infectious disease NP who's part of our team who follows all of the Hep C positive moms and babies. And so she'll review our list of patients that we're going to see on Sundays and tell us who needs labs. Of the 124 kids that we've seen so far in this clinic, no pun intended, there are 3 babies that are positive for hepatitis C. We have a developmental and behavioral pediatrician who is doing behavioral assessments at age 2, and we're hoping to expand that. Family planning is like my #1 thing that I care about in the clinic. I ask every mother at every visit, what are you using for contraception? And we work really hard because they just don't always go home from the hospital with a lark. And I tell them, like, the kiss of death for you is having another baby too soon. Like, it's really, really important for your baby and for you that you don't get pregnant too soon. And so I have a lot of moms that are on LARCs now. We have a direct line to one of the family planning fellows in OBGYN who will see a mom on the same day and put in a LARC. And sometimes you just, like, I think other people have mentioned this, you have to strike while the iron is hot. While they're there in your office and they're ready to go, you got to do it. You got to figure out a way to do it. And so we're lucky we work in a hospital where people are willing to help us do the kind of work that we want to do. We have had already a couple of subsequent pregnancies. One mom whose baby is in the hospital right now with her older child is 2, has been my patient since he was born. She relapsed, got pregnant during her relapse, and now has a second baby. We have addiction-trained a nurse prescriber, we have RNs, a social worker, a pediatric social worker who's really much more focused on the sort of child protection issues, and an adult therapist who's part of the Catalyst team who meets with the moms. Our patient navigator is really like a care coordinator. She's the person I'll ask to make appointments in OBAT or make a referral to a high-quality child care program, make sure the early intervention team is coming. There's an interesting amount amount of resistance to early intervention among our parents, which was also a surprise to me. And I think what I often hear, the number one quote from the moms when I say, how's the early intervention going? Oh, they came and she didn't need anything, she's fine. And that may be true some of the time, but every one of them qualifies in the state of Massachusetts just by virtue of being substance exposed in utero. But I think there's so much guilt and shame that the idea that there's anything at all wrong or that could be wrong, it makes people resist. So we often are like waiting until 6 to 9 months to make a second referral and get it going. We have a team coordinator who is the person that answers the phone when people call with questions. And there is a peer recovery coach, but she's on maternity leave right now. So we try to see babies once a week for the first 4 weeks after they go home from the hospital, because that's a really difficult time for these moms. And it gives us an opportunity to really get to know them and then to get to know us, to build some trust and to hear some of the stories that they just need to tell over and over again, and to talk about what it's like to have a newborn and to address some of the difficulties that they're having in the first month of life. We schedule them each time they come. I actually learned how to schedule patients myself in the Epic system, which has made it like really so convenient for me. Like, okay, I want you to come back in 2 weeks. I'm going to book your appointment right now. I'm not going to give you a chance to leave and not stop by the front desk. And actually, it's working like a charm. Like, our showing up rates are much better since the 2 pediatricians started booking our own appointments. And we try to see them every month for the first year of life. It's not always successful because, like all of you, some moms come from as far away as New Hampshire or Rhode Island, and they don't always make it. But if we book them every month, then we do get the vast majority of them for those 7 or 8 visits in the first year of life. We work really hard because there is, even though Respect takes care of them ostensibly until they're 6 months postpartum, that we noticed a lot of drop-off in transition to primary care, transition to like sort of ongoing care for themselves, getting their Hep C treated. And so we have sort of taken that on as, you know, part of our role. You can't have a healthy baby if you don't have a healthy mom. I've already talked about the Hep C, early intervention and ophthalmology, family planning, yeah. We work with a lot of community agencies. We just finished our first cohort of moms who did a curriculum called Sober Parenting Journey. There's a parenting journey organization that's based in Boston and New York that does parenting curriculums for, you know, parents of young kids. And they developed a curriculum a couple of years ago for moms in recovery called Sober Parenting Journey. And we just finished our first cohort, 14 weeks of classes. And we had 7 moms who came regularly to these appointments, and it was, now we're getting ready to do our second cohort, and it's actually at the hospital, and we serve them lunch, and we have childcare, and it's a support group, and it's a play group for the kids, and it's a place for moms to learn from each other. We also work with Jewish Children and Family Services has a program called NEST, Newborns Exposed to Substances Support and Therapy, which is a home visiting program. And they came to visit us and tell us about their services, and we apparently completely inundated them with referrals to the degree that they told us to stop because they couldn't accommodate so many. But when I see the moms who have a Nest home visitor, the kinds of things they tell me are, well, my home visitor is helping me get my driver's license back, or she helped me with my housing application. She got me into a program that provides diapers. You know, the kinds of things that these moms really need, and they just need a compassionate voice and someone to sit there and hold their baby and talk to them for an hour or 2. So I'm not going to belabor these slides about developmental outcomes because there really is not enough that's known, and very little of it is in the United States. So this is a study from Australia that followed kids, you know, longer than many other studies in the world, up through grade 7. And basically what we learned, which is not surprising, is that there are cognitive deficits that follow kids throughout life. The NAS group in this Australian cohort in New South Wales, the moms were likely to be younger, indigenous, have no prenatal care, less maternal education, and lower infant birth weights. So of course, that's a lot of confounding variables. But I think the bottom line is we need to be supporting these children in the long haul. This is a Norwegian study that many of you are probably familiar with, which I think is very interesting, which shows that their cognitive deficits, that there's sort of steady cognitive deficits for boys and increasing issues for girls as they get over, as they approach about the 8-year mark, which in and of itself is very interesting, and I don't know why that is. That's the same study. And then this is another study that, again, showed significant impairments in cognition, psychomotor, and some behavioral outcomes. In our clinic, I'm going to skip this one. In our clinic, we are seeing, interestingly, just in the first year of life, gross motor delays. And I was telling Carol this last night. One of my favorite stories is a mom who, at the 9-month visit, I asked her if the baby could pull to a stand, which is a very typical pediatrician question at 9 months. And she said, "What do you mean?" And I said, "Well, if you put her on the floor, can she pull up to the coffee table or the couch?" And she said, "I don't put her down." And I said, "Why not?" She said, "Well, they told me eat, sleep, console." And she thought those were directions, that she should be feeding the baby or holding the baby unless the baby was asleep. So the baby was not surprisingly overweight and motor delayed. And so that was like a real wake-up call for me to make sure that moms know these aren't directions for you. We're not telling you this is what you should be doing when you take the baby home. But we have seen 124 kids. We have 101 kids that are active right now. And the reasons for that are people move, get placed in a shelter, get sent to foster homes that are far away, or end up living with family members that are not close. And we have 85 moms, 4 sets of twins. We've had 1 maternal death, a mom who overdosed when her twins were 2 years old. 7 father deaths, 6 from overdose and 1 from small cell carcinoma of the lung in his 40s. We've had 17 maternal relapses and 12 babies that went directly from the hospital into foster care, which did not go home with their moms. So these are the moms that we've seen in our clinic so far. The age range is quite huge. The youngest moms we've seen so far was 19. The oldest is 40. The 19-year-old has had an opiate use disorder since she was 11. She was trafficked. She's had an incredible trauma history. In fact, another very poignant story, she came in when her baby was maybe 4 months old. She was living in a residential program where she had chores that she had to do, and she came in and she had this huge burn on her arm. And I said, "What happened to you?" And she said, "Well, they made me cook dinner. I had to make spaghetti. I've never made spaghetti before. Just the most basic, like boiling water without burning yourself." She had really not been nurtured in a family in her entire life. And my fantasy for some of the young moms is that the mom and the baby go into foster care together. That the mom gets nurtured by someone who takes care of her the way a mom would take care of you if you just had a baby. That baby is now about 18 months old and is actually surprisingly doing incredibly well. I did not have high hopes when I first met her, and again, you just can't judge a book by its cover. She's done much better than any of us expected and has not had a second pregnancy, and we're all incredibly proud of her. Half of our moms, about 52%, actually have other children, as many as 5 other children, and some of those children are no longer in their custody. Some of them have been adopted away or are in foster care or in kinship placements, which is a real source of anxiety for mothers when they deliver a new baby. It triggers their sort of ongoing chronic grief about having lost their children and feelings of remorse and guilt and shame about not having been able to do it before. Polysubstance use is definitely the rule rather than the exception in our clinic. There's something that is called the Boston cocktail, which includes Adderall, gabapentin, Klonopin, opioid. And so I think this is part of what makes following these babies over time incredibly challenging, because you just don't know which substance they're reacting to or what impact it's having on their neurodevelopment. 90% of our moms are smokers, 72 are Hep C positive, and virtually all of them have a psychiatric diagnosis on their problem list. The big ones are post-traumatic stress disorder, depression, anxiety, some moms with bipolar, some with personality disorders. And the question in my mind is always like, which came first, the chicken or the egg? I do think that I hear a lot of stories about childhood trauma, and I think a lot of the substance use disorders to begin with were self-medicating, early in life. So at Boston Medical Center in general, we serve almost entirely a population of color. So in our SOFAR population, that ratio is flipped. We see more white moms than we do in the rest of the hospital. 57% of our moms are on methadone, about 30 are on bupe, and some are on no medicines at all. The early onset of substance use is something that really, really surprised me. I had a mom tell me that she started drinking in first grade when she was 7 years old. And as a primary care pediatrician, I do not think to ask those kinds of questions of kids. And I think we need to be thinking as a pediatric practice, how are we going to address the older kids? We now have a cohort of kids that have been reunited with their moms that are, up to age 12. The oldest one is 12. These kids are right in that risk category, and I don't think anybody has any idea how to help them develop their own sort of distress tolerance and ability to cope when their risk factors are enormous. Most of our moms are from families with, multi-generational substance abuse, but we also have some that, we would call downwardly mobile, who grew up in middle-class families in Tony suburbs of Boston, and for one reason or another, ended up developing an opioid use disorder and are, living on the street outside our hospital. And one mom I have, her dad is a judge. Another mom, I asked her, like, what are you doing at Boston Medical Center? And she said, well, I'm a junkie. When I was in college, I started popping oxys because my boyfriend was doing it, and within a few years I was a heroin addict. And so that's sort of interesting, because we do not see that population at Boston Medical Center. It's a safety net hospital, and we see very few people from suburban communities around Boston. So what have we learned? We've learned that the families are incredibly vulnerable, and they need a lot more support for a lot longer than we think they do. I've already mentioned the loss of other kids. Many of our moms have had sober periods before and relapsed, and we tell them, well, that's something to build on. You've done it before, you can do it again. We are here to help you. We always ask everybody if they have been incarcerated, and in fact, sometimes our moms are like, I know you, they see each other in the waiting room. I know you, we were locked up together. And I'm very interested in those stories, because I hear everything from it's the worst thing that ever happened to me to it's the best thing that ever happened to me. That was the way that I got clean, is I got locked up. And why are they locked up? They're locked up because of the behaviors they engaged in when they were really in the throes of their addiction disease. Some incredible stories that I won't share with you now. Lots and lots of loss. One of the things that I have started doing is asking every mother about their tattoos, because almost all of them have tattoos. And I learn a lot by asking, who is this and who is that? This is my brother, this is my baby's father, this is my father, this is my best friend, this is my sister, dead from opioid overdose. I also asked them how they chose the names of their babies, and that's sort of a fun question in pediatric practice in general, because you can learn a lot about a family when you ask those questions. And often they're named for, people who have died of overdose. And right now I have two babies in my practice, one named Savior and one named Messiah. And another very common quote is, this baby saved my life. And there's nothing I wouldn't do for this baby. I'm gonna get it right this time. And I do say that's a lot of pressure to put on a 6-pound human being, but we're gonna try to do this together. High motivation. They're very, very motivated at the beginning, and I think that's our opportunity. Incredible anxiety. They almost all have anxiety disorders, and we see just tremendous anxiety about what we would consider as pediatricians to be really trivial things, like neonatal acne does not require a visit to the emergency room. A cold. I just saw a mom who went to the ER twice for basically a stuffy nose in the first month of life. We are working really hard to try to reduce the ER utilization and to do a lot of education very early in the baby's life. The moms that are in programs that support recovery do seem to do better over time, but they're not easy places to live either. A lot of the moms are isolated from their own families of origin because of their behaviors. A lot of families just say, I can't do this anymore. You know, you stole everything from me. The mom whose dad is a judge told me that she and her boyfriend broke into all the houses of her parents' friends, you know, in this very Tony suburb. That did not go over very well. And, you know, she's very isolated from her family because they just can't forgive her for that behavior. Lots of stigma. The moms feel very judged. They're very defensive. They're very quick to be offended by a look, a comment, and that we need to work on our teams really, really carefully to make sure that they understand that we get it. We talk to parents about a relapse plan. So it's part of every one of our primary care visits is, what's your plan if you relapse? I want to document it in your baby's medical record. Who will take your baby? Who do you want to take care of your baby? Who's equipped to take care of your baby? And we document it during the visits. The infants are hard. Huge range of length of stay, which you probably know better than I do, but some babies go home at 5 or 7 days, and I have a couple of babies in the house right now that have been there for 2 months. Just really hard to feed, like dysregulated sucking and swallowing, still very irritable, can't be weaned. We try to wean them. They need to be restarted or started on a second agent. And this is something that our neonatology researchers are very interested in figuring out why. I mean, one baby I have right now is same mom and dad, same substance exposure, dramatically different NAS course from his brother 2 years ago. And so there's just so much work to do that I think you guys are smarter about than I am. Lots and lots of feeding difficulties, so we are now incorporating a feeding specialist, an RD, who's also an IBCLC, who's coming into the room with me when we're having babies that have really dysregulated feeding or difficulty with suck and swallow. Everyone thinks their baby has more gas than average. Very gassy, he's in a lot of pain. I changed the formula because my friend gave me Alimentum or NeoSure or some highly elemental formula. Nutramigen is a favorite right now. And so this is something that I was talking to Michelle Walsh about last night, because I, as a pediatrician, I'm like, why would they need a highly specialized formula? And apparently there's some data that the low lactose formulas are better and easier for these babies than a typical formula. And the moms are figuring that out on their own. We've had 11 babies that have been removed in the last year from their parents' care due to relapse. 12 older children reunited with their parents. Often a mom doesn't have stable housing, loses her kids, gets pregnant, and in Massachusetts she gets, a sort of stable place to live for a short time, and then her older kids come back to live with her. My experience suggests that this is a really not a good time to reunite a mom who is so vulnerable in the postpartum period, to bring back, a 2- and 5-year-old when she's under so much stress and early in her recovery. And this has not gone well for most of the families that we have watched. The older kids have a lot of difficulties with behavioral dysregulation, ADHD, executive function, school problems, and they're at very high risk for substance use disorders themselves. I think we have a lot of work to do with supporting the reunification process, which is it's just stunning to me that these kids are picked up one day and sort of brought back to their mom with very little support around that process. One thing we've noticed is a lot unexpectedly, or maybe expected, we should have expected this, a lot of overfeeding. and a lot of moms that they just want to feed their babies. One mom, I'm going to show you a growth curve in a minute, who came to meet me for the first time with her baby when he was age 1, got him back from foster care, and said to me, I just feel so guilty that I wasn't there, that I just feed him. And so lots of kids who are SGA when they're born, or maybe AGA when they're born, but by 1 year, and sometimes even before that, meet criteria for obesity. And these are really tough conversations to have. So in a non-SOFAR population, we spend a lot of time as pediatricians trying to address early origins of adult disease and obesity in early childhood, so we're not setting them up for later onset of cardiovascular disease, diabetes. And as you can imagine, in this population, it's even more difficult to have those conversations because feeding is comfort and care. This isn't showing up as well as I would have expected, but this is a baby who's now only a little bit over 6 months old. This is a fairly typical sort of rapid rise in weight in the first 6 months of life. Here's another very typical, I know exactly who this baby is, who you can see the rate of her growth, and I should have showed you weight for length curves instead of weight curves, but they're not that different actually, because the height does not tend to go up nearly as much as the weight. And trying to address this with moms is stunningly difficult because they just can't not feed their baby. This is the growth curve of the baby who came back at age 1. So I first met him when he was a 1-year-old, and he was about 25 pounds, and by 2, not even 2, he's 50 pounds. And his mom, and he's got an older brother who's 140 pounds at age 8. And mom just cannot do it. So we're working really carefully with our feeding team and our nutrition specialists and our Nutrition for Life program to see if we can help her. And now we're sort of learning that this is an issue we need to address. Dads tend to also be in recovery. Some of them are still actively using. Some are incarcerated, some are deceased from overdose. They're less likely than moms to be engaged in their own care, and we actually, if they come into clinic, which they sometimes do, we use that as an opportunity to get the fathers engaged in their own primary care and Hep C care as well. And we have actually successfully treated a number of fathers for hepatitis C. A few dads actually bring in their kids because they got custody rather than their mom. I've heard some really poignant stories from fathers about their own multi-generational substance abuse histories. And one dad said to me recently, he grew up in the foster care system because both of his parents were heroin addicts. And he, in turn, became a heroin addict himself. And he said to me, I just don't understand why this happened to me. Like, I wasn't even raised by them. I was raised by a really great family, and I got a substance use disorder myself, and gave us an opportunity to talk about the risk factors just based on your biology and your history. And the other thing that I find so incredibly interesting and poignant is that this man, this young father, is now living with his own biological father. The wish that our young people, our young parents have to reconnect with the biological parents who couldn't care for them when they were children is really profound. And a lot of them are seeking out their biological parents, when they're in their 20s and 30s. Fascinating. Trauma, a lot of psychiatric comorbidities, poor physical health, this was mentioned earlier, poor nutritional status, poor oral health. This is another initiative. By some miracle, we are actually on the same floor of the hospital as the oral surgeons. And so we are now starting to get mothers engaged in their own dental and oral health care because they ask for it. They say, like, I want to apply for a job, but I'm embarrassed about my teeth. And we know that poor oral health is associated with all sorts of bad health outcomes. And so we have the oral surgeons on board to help us, same time, same visit. We just need childcare for the baby so the moms can go to the dentist. A lot of social isolation. A mom of mine was recently filed on because the bus driver who took the child to daycare could tell that she was impaired. He filed, And they did an emergency response, and her apartment was just filled with all the paraphernalia of her addiction. The baby was, the breastfeeding 14-month-old was urgently removed from the mother's custody. And when I ran into the mother on the street outside the hospital, she said, "Oh, I'm so glad they took her. There were 3 or 4 days when I don't even know if I fed her." And I said, "How did this happen?" And she said, I started isolating myself, and I should have known that that's really bad for me, because when I get isolated, I get depressed and I pick up. I think we've covered all of this. I think the most important thing is that the care of the parents improves the care of the babies. That's the way to take care of a baby, is to make sure they have healthy parents. And I think we've covered a lot of this territory. I just wanted to make a special note about twins, because I think multiple gestation is just incredibly challenging. It's hard enough. You have a set of twins. So we've had 4 sets of twins, and none of them are with their parents anymore. So the first set, I mentioned the mom who overdosed. Their father died, and her sister died of opiate overdoses during her pregnancy. And she died when they were 2 years old in a shelter. They were in the playroom. She was in her room, and she overdosed and died. The second one, mom relapsed. She called 911 on herself because she put cocaine in the nebulizer for one of her babies. And she knew that she was so impaired. And so they were put into foster care with her father and his wife. And she grew up in foster care because that dad could not take care of her. He's now in recovery in his 50s, and he said to me, "I'm going to make it up to her by taking care of her kids, because I didn't take care of her." Another mom relapsed. The dad just can't take care of the twins, and so those babies are up for adoption. And the 4th set, who are very little right now, they're 3 weeks old. I just saw them on Tuesday. That mom was very sick throughout her entire pregnancy, never really got into recovery, and they immediately went to foster care. So I think the multiple gestation thing is something for us to all think about, that it's just really, really hard to take care of a set of twins. As a team, I think it's incredibly emotionally challenging work, and we need to take care of each other. Lots of challenges, lots of competing demands for the mothers, all these appointments. I mean, one mom made an Excel spreadsheet of all of the things that she was expected to do over the course of a week, and I thought, there's no way that I could do this. Her methadone appointments, her groups, her probation officer, drug court, you name it. I just don't know how any human being can do it. Sometimes they're taking care of other kids or other family members. The transportation is a huge issue. Unstable housing and poor access to high-quality childcare. For us as a team, the trying to get people to be more or less on time for their appointments. My clinic starts at 1. It's supposed to be 1 to 5. I'm usually there till about 7, which is fine for me. Like, at my stage of life, I don't have little kids to go home to, but it's a lot to expect for somebody in practice who has a place they need to go when they're done. Some of the shelters require people to be working when they're 8 weeks postpartum. I mean, I wasn't working when I was 8 weeks postpartum. I give the young pediatricians in my office 4 months off after they deliver a baby. Why should we expect these moms to be able to do this? Communicating with the adult providers that are taking care of our moms is a very interesting challenge because of HIPAA. And so we have developed a 2-way release of information. We need to be able to talk to the OBAP providers, the OB providers, the psych providers, and they need to be able to talk to us, because that's the way that we're going to support these families. Only 30% of our moms keep their postpartum appointments with OB, so we are actually going to embed a family practice doc in our clinic so that she can do some of the addiction care and the postpartum visits for the moms when they come in for their 1-month or 2-month visit. I'm running out of time. I've got the stop sign up there, so I'm just going to stop by saying your average pediatrician in America is really not knowledgeable about how to care for these families. And I think that that's part of our job in the SOFAR clinic, is to sort of educate, to start a national dialogue with pediatricians about how do you support these families. Even in my own hospital, when I read primary care notes from excellent pediatricians with the mother in addiction, There's no mention at all in the note that the mom has a substance use disorder. It's like the elephant in the room. If I don't mention it, it's not there. But it's actually all the mom is thinking about. Are you guys familiar with the plan of safe care? Like a document, we are starting to do this now, documenting in the mother's record. Lots of ideas for the future about what we should be thinking about. I have a lot of questions about the Eat, Sleep, Console protocol. I'm not convinced as a pediatrician that it's really serving our families as well as we think. It's very sexy because it decreases cost and length of stay, but I worry that the babies are still very stressed and that the outcomes when they go home are not as good as we would expect. In Vermont, they do a family assessment at 36 weeks so that the mom is not filed on like at the moment of highest stress right after delivery. So they do, the Child Protective Services assesses the family at 36 weeks, makes a decision then about whether or not they need to be filed on when they're born, and a significant proportion of them don't. I'm going to stop by saying I believe in recovery. I grew up in a family with an alcoholic father who became clean and sober at age 50 after trying for a long time. I was a senior in high school. And it was really transformative for us as a family, for my parents' relationship, for my relationship with my father. And I really do believe in it. And I tell parents that. I want them to know that like it affects everybody. And one of my favorite stories is that one mom turned this into, she told the ID doctor that she loves Dr. Costello because Dr. Costello was an NAS baby herself. So I'm very popular. I'm not exactly sure where that came from, but it's very funny. And anyways, so that's what we're doing, and we feel like we have a long way to go. Thank you very much.